Your next patient is Mrs. Jones, who presents with throbbing pain on the right side of the head. Migraine is a common primary headache disorder. Today we're talking about the diagnosis and management of migraine. Hey friends, welcome back to the channel. If you're new here, my name is Dr. Erwin Kwun. I'm on a mission to help doctors lead a happier and fulfilling life. Migraine is characterized by moderate to severe headache and is usually accompanied by symptoms such as photophobia, phonophobia, nausea and vomiting. At least 60% of patients experience nausea and vomiting during a migraine attack. Migraine is thought to affect about 1 in 7 people globally. It is 2 to 3 times more common in women than men. Migraine headache is typically unilateral, but in 30 to 40% it is bilateral. As migraine can be bilateral, it is therefore essential to consider a diagnosis of migraine, even if headache is not unilateral. The onset of headache is gradual and often characterized as pulsating or throbbing. A migraine attack lasts 4 to 72 hours. Predisposing factors or triggers of migraine include stress or period of relaxation after stress, anxiety, sleep deprivation or depression, dietary factors including cheese, chocolate, alcohol and citrus fruits. Oral contraceptives may exacerbate or precipitate migraine attacks. It is helpful to go over the 4 stages of migraine to understand the progression of an attack. Not everyone will experience all the 4 stages. The first stage is a prodrome. This typically occurs 1 or 2 days before the onset of headache. Patients might notice subtle changes that warn of an upcoming migraine. These symptoms include fatigue, poor concentration, neck stiffness and yawning. The second stage is aura. Approximately a third of patients with migraine experience transient neurological symptoms minutes to hours before the onset of headache. Visual symptoms include zigzag lines or scintillating scotoma. Sensory symptoms include numbness, pins and needles sensation in the hands that goes up to the arm and face. Some patients may experience paresthesia or numbness without headache. Consider the possibility of transient ischemic attack rather than migraine if a patient presents with unilateral paresthesia, especially if the aura seems to be different to what they usually have. The third stage is a migraine attack, which can last from 4 to 72 hours if left untreated. The fourth and final stage of a migraine attack is a prodrome. Prodromal symptoms may occur after resolution of the headache and last up to 2 days. These include fatigue, elation, or depressed mood. We can classify migraine into migraine without aura, migraine with aura, migraine aura without headache. Depending on the frequency of the attacks, migraine can be classified as episodic or chronic. Episodic migraine occurs less than 15 days per month. Chronic migraine occurs at least 15 days per month for more than 3 months. The headache must not be better accounted for by another diagnosis. A comprehensive clinical assessment is essential in the diagnosis of migraine, as other causes of headache can present with similar symptoms and signs. Assessment of headache starts with a careful history. It is vital to understand the history of the headache, impacts upon patient's life, and the health agenda. It's essential to assess for the presence of signs and symptoms suggestive of serious underlying pathologies of headache. Examination involves cranial and peripheral nerves, fundoscopy, blood pressure, and head and neck. In a person over the age of 50 years, assess the temporal arteries to rule out giant cell arteritis. Investigations are not generally required to diagnose migraine. Investigations may be requested if you suspect an alternative diagnosis. This would include a CT head scan, blood tests including full blood count, CRP, UNEs, and LFTs, a lumbar puncture. Prognosis of migraine improves with increasing age. In pregnancy, most women will notice an improvement in frequency and severity of attacks. The International Classification of Headache Disorders have come up with diagnostic criteria for migraine without aura. Headache lasting 4 hours to 3 days, nausea or vomiting or light and noise sensitivity, 2 of the following: unilateral pain, moderate or severe intensity pain, aggravation by simple physical activity, pulsating pain. At least 3 of the following criteria should be fulfilled for migraine with aura: reversible focal brainstem or cortical dysfunction, aura develops over 4 minutes, or 2 auras in succession, each aura lasting less than 60 minutes, and headache less than 60 minutes following aura. Differential diagnosis of migraine include tension-type headache, cluster headache, sinusitis, medication-induced headache, giant cell arteritis, and idiopathic intracranial hypertension. Let's take a look at the management of migraine. It is helpful to ask a patient to keep a diary of the headache so that they can identify potential triggers such as stress, specific food, dehydration, missed meal, or disturbed sleep, and monitor the effectiveness of treatment. Management of acute migraines include trigger avoidance where possible and lifestyle modification. Educate patients about lifestyle changes, for example, making sure that they're drinking sufficient fluid to avoid dehydration, avoid eating specific food that might trigger a migraine attack. Pharmacological treatment of migraine include simple analgesia such as paracetamol, ibuprofen, or aspirin. Patients can be started on triptan or a combination with a triptan and simple analgesia. Oral sumatriptan is a first choice for a triptan. Other triptans should be offered if there's no response with sumatriptan. If a patient struggles to take oral medication due to vomiting, consider a non-oral formulation such as intranasal or subcutaneous triptan. An antiemetic may be added. This would include prochlorperazine or metoclopramide. If a patient experiences attacks that are frequent or prolonged and severe despite appropriate acute treatment, or the person is at risk of medication overuse headache, prophylaxis treatment should be considered. This includes propranolol 80 to 160 mg daily, topiramate 50 to 100 mg daily. Topiramate is contraindicated in pregnancy. Amitriptyline is an alternative medication that could be used as a preventative treatment. Prophylaxis treatment should not be initiated in primary care for pregnant or breastfeeding women or children. Consider admission if serious cause of headache is suspected. The patient has severe uncontrolled status migrainosus. This is a migraine that lasts for more than 72 hours. Complication of migraine. If the diagnosis is uncertain or the patient has not responded to treatment in primary care, a referral to neurology is indicated. If you have found this tutorial on management of migraine useful, then you may want to watch a tutorial I've made on how to assess headache. This is a tutorial where I go over how to take a history of a patient presenting with headache. Click the video to watch it. Thank you for watching this video until the end. If you have any questions or any suggestions for future videos, please comment below. Take care everybody. Bye bye.